The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery. and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
All right, and good afternoon, everyone, and welcome to PerfWeb 29. We have a heck of a show for you this time around. We're going to be talking about some really interesting things. We're going to be talking with Roger Delong about recirculation, measuring your recirculation in your ECMO cannula. We're going to be talking about the good, the bad, and the ugly of VADs and ECMO. And we're going to be talking about something very interesting, I think. And the VADs and ECMO are going to be Dominic Cappelletti. He's a new member of our faculty and coming to us via Skype. In fact, everybody's coming via Skype. And then also Dr. Keshin Mathura from Amsterdam is going to be coming in talking about Sidestream dark field imaging. That's going to be, I think, for me anyway, it's going to be a very interesting talk. I'm looking forward. They're all going to be interesting. They're all going to be great. So before I get started, though, with my introductions, which I need to do, of course, and talking about these other things, I want to talk about something we're doing that's new. So take your phones out and go to slido.com. Do you have your phone?
I don't.
How come?
I'm not allowed to have it.
She can have her phone up here. Somebody get Tammy's phone. Slido.com. Everybody needs to go to slido.com. And you're going to use hashtag, you'll see the hashtag there, PerfWeb29. And so we're going to do several polls. I see you over there, Roger, doing it. That's great. Look it up. Do it. That's great. And we're going to be asking several polls throughout the program. And the first one is up right now. So you can go ahead and answer those polls at your convenience. I'll keep up with my opening remarks, and you can, and then we'll look at the results a little bit later on. So while we're doing that, we're on all social media platforms, as you well know. That's the YouTube, the Facebook, the Twitter, the LinkedIn, and it's very important. I really need you guys to like, share, follow. Most importantly, please subscribe to our YouTube channel, click the bell for notifications, and give us thumbs up or likes or whatever it is, loves, anything you can on all of these various platforms, wherever you may be watching us from. Those are very important to us. I talked about our new LinkedIn account already. I think that's up there. Our new call-in number, we have a new call-in number, is right there, 832-239-5358. We would love to hear from you, so if you want to give us a call, please do. We'd love for you to join our faculty. Our faculty page shows our resident faculty that currently is with us. Of course, we're adding to it every time. Can we show that page, Dave? Our faculty page? Oh, you didn't put it up this time? Okay, so you go to perfweb.us. Yeah, so go to perfweb.us, click on faculty, and you will see all of the members of our current resident faculty. Dominic, in fact, took us up and called us and said, hey, I want to give a talk. This is the talk I want to give. He sent me his slides and information, and it was fantastic. Was it a tough case, Tammy? Tammy just blew in, by the way. Okay, so immediately to my right, there should be two other people here, but Tammy is here. She just finished a case last minute at a hospital. Fortunately, not too terribly far from here, but I'm sure the traffic was no fun. And so you all know Tammy. She's been with us several times. Patrick isn't here, but coming via Skype for our first lecture is Roger Delong. I know you all remember Roger from our last conversation that we had, or last lecture that he gave, where we had all those technical difficulties. We blamed those on Roger. And but now I think we have a lot of those technical difficulties resolved, and so we're going to go ahead and go forward with Roger's presentation. Roger, just so you know, is a perfusionist, but now not practicing at the moment. I'm trying to convince him to go back into perfusion. He left and went to industry, and he worked with Transonic for a number of years. And he worked on their ELSA meter, which I think is what you're going to be talking about today. And he also has technology, which was his last presentation, that measures clot burden. And he also talked about other ways to measure clot burden, and I think really taught us a lot about just how much clot really exists. But right now, the whole idea of this talk is to discuss recirculation in your VV ECMO and a tool to help reduce that, identify it, and reduce it or fine-tune your cannulation, okay? So,
can you get Roger to talk to you?
oh, Roger, can you say something?
Hello.
Hey, yeah, we hear you. Okay, they needed to check your mic. So you're
right.
good. All right, so without any further ado, I'm going to turn this over to our eminent first speaker, Roger Delong.
All right.
And he can share his screen. Now, we're looking at ourselves right now on the program.
Okay.
Oh, okay.
David was how to do it. It works. Can you see? What are you looking at?
Oh, he had it. He had it. There it is.
Okay. Will that work?
You may want to go to presentation mode.
Yeah.
There you go. Now you're perfect. And then close that little window. Yep, there you go. Now we're talking.
All right. I'm trying to keep it general as far as the different aspects of recirculation and what causes it, and I don't want to get too far out in the weeds. I did a familiarity with the industrial side with different things that are being done to measure it. Hopefully you can just explain a few things that will help understand the dynamics of the flow. As I always go to first, you have the main ELSO data sheets that are showing a surprising, if not shocking, rise in centers and cases. I haven't seen this since 2016, but the graphs they put up that year kind of struck me as a little more informative. Here's the same case numbers tracked, but these are showing the proportion that die. This is the respiratory portions.
Oh, wow.
Some fair success, and this is the cardiac portions. So although it's wonderful, those red bars show nice growth and everything else, we still have a lot to know about that we don't, obviously, because the yellow is bad outcomes. We're showing a short-term survivability just over 55%. It's not moving fast. and a lot still needs to be done. So let's talk about the different factors of the recirculation. Most people know a lot of this. This will get a little bit deeper pretty quick. The cardiac output, obviously, if any of us were on ECMO right now, there would be some recirculation, but it'd be minimal, 5–10%. If you have a dead heart, it's going to have 100% recirculation. Some is normal and expected, but you want to minimize it, obviously. The volume status, if you have enough volume, then the patient can move through the heart fairly well. If there's not enough volume or too much volume, that can adversely affect the rise in recirculation too. The cannula types, most commonly these days, it seems from my travels, it's been dual lumen cannulas, either Origins or Avalons. I am seeing a rise in the crescents, but there's still a significant number of people that are using single lumens, pairs of them. They all still have the similar problems. Cannula placement is the most important thing, and the smaller the patient and the smaller the cannula, that can really be hard to track. There's different methods. Every intensivist I know seems to have their preferred methods, but none are deadly accurate. And then last is the flow rate. How much blood can we stuff into a heart and expect it to move through the circulation versus going back into the lower pressured return ports? Couple of points to remember. All VV ECMO has some recirculation. Optimize everything, the volume, a good heart, good placement, everything. You're still going to have some recirculation. You've got delivery ports within millimeters of the negative pressure ports, and it's going to pull some blood back. Secondly, the recirculation, in essence, what it does is it reduces the effective blood flow, and therefore limits the oxygen delivered, which is the whole goal of what we're shooting for. So anything we can do to reduce that is going to shorten the run and have better outcome. Thirdly, and most problematically, when you get highly oxygenated blood coming back through the venous line, it skews the venous saturation number, and it renders that line saturation unreliable. You can't use that. And unfortunately, that's kind of the primary way it gets measured most of the time. Here's an idealized cannula flow, in this case a dual lumen, where the red arrow shows the blood boldly passing through the tricuspid valve and all of the superior and inferior flow going uniformly into the exit ports. It's shown similarly with the Avalons, with the Crescent. They all show how perfectly they work. On the left, we have single lumen cannulas. They share the same problem. On the right, the Origin. They all are going to return some blood to the negative port. But that flow really, at this point, everybody understands these diagrams. But at some point, there's some question, okay, what exactly is going on in there? A study came out last year from this guy from Turkey named Jamil Mohammed. He was the first one to run a flow dynamics study on what happens when you have a cannula placed correctly in the right atrium. You have a 3-month-old, and they've run different flow profiles and recorded them pretty well. In this case, they used the Origin, and this is the smallest one. I think it's a 13. And the port for the tricuspid valve is, if you haven't seen this, is on one side, and on the flip side, there's 3 upper ports, proximal ports for drainage for the SVC, and 1 distal IVC port. Very small. If you ever get, if you don't do peds, get one of the 13s in your hand. You'll be amazed at how small these things are. Here's a diagrammatic view of what he did. Here's a properly placed cannula with a tip just at the north end of the IVC, and the delivery going right towards the tricuspid, which is kind of at an angle askew in the top right corner. Okay, so far so good. We understand that. But what happens to the blood once it is placed into the right atrium? On the right, they scaled it by residence time, meaning how long it hangs out before it goes back. The delivery line in blue, of course, is 0 because it hasn't been delivered yet. But as it spins around over time, you can see the green turning to orange, turning to red. And the red shows blood that's been hanging out, generally on the cannula side of the atrium for about 2 seconds. That's more than 1 or 2 cardiac cycles. That's quite a while. Here, the colors are shown by where they're coming from. In the upper left, you have the delivery port in red. You can see that it's properly placed, but since the atrium is, in essence, pretty much round, if not oval, some blood's going to quickly escape through the tricuspid, but the rest of it's just going to spin around. And as it does, it delays that time that it goes forward or waits until it gets picked up by the ports. In the upper right, there's very little residence time for anything that escapes through the SVC ports. Those pick up like 90% of the total blood that's returned from the atrium. Lower left, you have the IVC port, which doesn't apparently do its job well. There's a lot of lines, a lot of residence time, a lot of hanging out in the atrium. So a lot of the blood coming from the IVC is not going to go into the proper port. It's going to spin around. Since the studies come out, I'm sure that the cannula makers have been looking closely at this and are trying to change the geometry of these cannulas. Here's a case where they pushed it forward on the left and pulled it back on the right to slightly improper positions. On the left, it's a little bit too distal, and you can see the delivery of the blood is right up along the right wall, and it's just spinning in a very circular fashion, almost at a real slight angle with the tricuspid. So it makes it a lot harder for that blood to leave in its proper direction. In the bottom right, you have where it's proximal, and the driving force, the delivery, is going right up through the middle and forcing kind of a figure 8 pattern. Again, most of the blood on the right is going into the tricuspid, but anything on the left is just spinning around for quite a while before it's picked up. A good study was done by Joshua Walker, who's an excellent perfusionist. I think he's in San Antonio. This is back in 2009, where he was studying the mixed venous saturation in VV circulation. And in the conclusion, he said, calculating the SvO2 in VV ECMO, it fails to consider the influence of the high PO2 of arterial blood. Fairly well known, but it leaves us going, okay, then what? In the ELSO recommendations that came out in 2015, they addressed the veno-veno recirculation. And on the first page, a bold disclaimer, these are not necessarily consensus recommendations, implying that every intensivist you'll find has different levels of belief as to whether this is the effective or not effective way to go about this. Some believe in it strongly. There's been a lot of good studies to disprove that the mixed venous SvO2 is at all reliable. Basically, for this, the recirculation percent is calculated off the saturation, the pre-saturation on the left divided by the post-saturation on the right. And without getting too heavily into the math, if you raise the number in the denominator on the right, the number gets lower. So if you have an artificially raised post-SvO2, you're going to have an artificially reduced percentage of recirculation. Right. Again, they're saying none of these methods has been definitively shown to accurately measure the percent. But why do they percent them then? Well, that's really all they have. Here are the 5 recognized methods by ELSO. You have a centrovenous line, which is used to draw some blood samples, again using the SvO2. Then your straight SvO2 calculation. Ultrasound dilution, we'll talk about that in a little bit. Thermal dilution, we've kind of mentioned that before. Thermally, blood doesn't mix instantaneously. It's not very fast, and it's not very accurate. Commonly known, a Swan-Ganz may be off 30–40% in some patients. Trending on the bottom, that's somewhat useful. If you have an error this time, hopefully you have a similar amount of error an hour, 4 hours, 8 hours from now, and you could watch the trend to see if something's migrating or the fluid overload or underload is a problem, etc. The upper two, back to the SVO2. The SVO2 and the central venous line are both based again on the SVO2 levels. Pre, no problem. Post, big problem. You can't really measure with those. Thermal dilution has been mentioned in multiple papers. It's pretty well recognized. The Russ and Steiner have done some good work in Germany that showed, okay, what happens if I purposely overload or underload the patient with volume, if I purposely drive the flows up or down. This is an animal study, which we don't care for animal studies as much as human studies, but you still need to know what happens if you purposely want to see it higher or lower for the different factors. Some places rely on a Doppler. They think they can read this and tell exactly how much is coming or going. That's a bit of a magic trick to me. It's not real useful, and a lot of places don't even use it because they come up with kind of muddled answers. Ultrasound dilution has been around since 2008. This is a pretty effective method. Simple injection upstream of saline. The ultrasonic wavelength of saline is much different than blood, and it goes through the arterial sensor, just like your normal sensor on your heart-lung machine. And whatever comes in and then immediately out of the patient is measured and compared. It measures very well. It doesn't matter if it's thoroughly mixed or not. It does pick up the difference in wavelength, and it's a simple fraction. If you're giving 400 cc's of blood, well, you're getting 400 cc's of blood, but how much of that blood went through the patient and how much went directly back? Well, if you put a saline marker in there and can measure it, then you could know right away what percentage. I'm giving 400, but I've got 25% recirculation. Well, there's no way to know it unless you can measure it. And in this case, I would get back a value of 25% because the second blue sensor would know what the venous percentage is. All right, this is what the screen on that looks like. It compares the two. This is the bolus, the venous return. The recirculation percentage is simply the venous over the arterial. But the magic number here is the effective cardiac flow. This is the number we need to know, but can't know any other way. We can see the 640, we know what the pump's giving, but how much is going through the heart to the patient that needs it, and how much is coming directly out? That blue number is exactly what we need to know. Optimizing the cannula position, as you recall from these diagrams, is pretty important. But how do you know unless the patient moves the cannula on their own, or whether you just think their recirculation's high and you adjust the cannula, take a shot and see what the position is, has it been improved or hurt them, and then to stand back and wait and see if the patient condition continues to improve or decline. That's not a real direct, quick way to do it. The volume, the same thing. The idea of this is if you are hypervolemic, you have too much volume, it won't all go through the heart. It's pretty intuitive. But what happens to it? Well, it loiters in the atrium until it ends up going out through the cannula. So not surprisingly, you have a higher recirculation. What is surprising is that I thought was at the lower volume levels will also increase the recirculation, probably because of the change in the geometry of the right atrium, the location of the catheter because of the hypovolemia. I'm not sure anyone knows the answer to that, but at low levels it'll also do it. In this case, there was a patient, they added some saline, I believe it was the bolus, like 500 or 750, and you can see the recirculation dropped like a stone. Pump flow. Generally, if you want to just maximize the pump flow, what you do with a centrifugal pump, you have a linear relationship with the speed, but a nonlinear relationship with what flow goes through there. And generally, if you're maximizing the flow, Well, you dial up, up, up until the flow starts to fall off, and then backtrack and identify the maximum point, and that's the flow you're aiming for. But that, as we already talked about, if you've got more pump flow than the heart can accept, that's going to drive the amount of recirculation up, and not in a linear fashion. It's not quite logarithmic, but it'll certainly be geometric. And if you were going to compare two methods of just blindly setting a pump flow based on what the pump's happy with versus shooting a number and measuring, pretty easy to see. In 2 minutes time you could find the answer by just simply measuring it. Here's one of the results by the Russ Steiner group showing they were looking at acute lung injuries. That's what the two lines are indicating. But the point of this that I thought was important, if you read across the bottom, from 0 to 125% ECMO blood flow versus cardiac output, as soon as you get to about 75% and approach 100 in overdrive, you're going to spike upward sharply as far as the amount of recirculation. So, and it makes sense. If your cardiac output's 4 liters and you're stuffing 5 liters of flow into it, well, at least one of those liters is coming back, plus whatever would be coming back if it was more properly set. And all these go together to effectively raise the cardiac flow, which is the important thing. That's what we're trying to do. If you can maximize the pump flow, you're going to increase survivability and minimize the amount of time you're on the circuit. So, anyway, a short, quick tour through the flows. Any questions on that?
Nope. Yes,
Nope.
I'm sure we're going to have lots of questions. And that was, first of all, I want to applaud you for that really good talk. You want to stop sharing your screen so we can get you up and we can all be on the screen together? And I'm gonna ask you a question if I can, Roger. That was really incredible. Before I do, can somebody put up the poll answers that we got, and if there were any questions via Slido today, and open the phone lines as well if you don't mind. So, do you attend 80%, 20% no? All right. Out of 5, so we had 5 participants on that. I don't have any trouble going to meeting with 60%. Staff shortage is 40. No CEU budget. Don't like or can't travel, the same, 20%. And don't feel meetings have good educational value and information was 0, so that was good. Okay. We have any other questions, or was it the only 2? Okay, 2. Okay, good. So let's go ahead and put the other on. So Roger, let me ask you a question, if I can. Do you think that you would like to stay and answer questions now, or would you like for Dominic to give his presentation and then come back in and have a joint discussion with you and Dominic on your topic and his topic, which is, I think there's some synergy there between VADs and ECMO and that kind of thing that he's going to be talking about. What would work better for you in deference to your time?
I'm here for you, Joe. Whatever way you want to do it's fine with me.
Okay, very good. Then why don't we do that? Why don't we now, David? Are we going to be David and Magic? Are we going to be able to bring both Dominic and Roger and us all on the screen together to talk? I mean, is that a yes or a no?
It's right now?
No, not right now. We're going to do Dominic, his lecture, and then and Roger's going to hang out with us, and then we're going to bring those 2 together plus us and have a discussion before Dr. Mathura joins us and does his lecture.
Yeah, we should be able to do that.
Okay, then let's go ahead and do that. Let's ring. So Roger, if you'll just hang tight, maybe
Sure.
watch Dominic's lecture. Let's go ahead and ring Dominic up and go ahead and get him started. And we can take that poll down, and then we can go to to the next poll questions, which I can bring back up.
Let's see if we can bring him in. We're a little early.
Yeah, we're a little early, but if he's not ready, then we'll go to the next thing.
Second vote, thumbs up.
Oh yeah, and everybody, thumbs up, please, if you don't mind, On the YouTube, click the thumbs up. On the Facebook, click whatever it is you're supposed to click. Like. On the tweets, what did they do on tweet? Something to, like, hit the love button. So, like, when I see the politicians who have all these followers, you see all these symbols going up, love and thumbs up and stuff. I want that for us on the tweeter. Can somebody do that for us, please? Can you click it more than once or just once? I don't know. You don't know? You're not a tweeter?
No.
Neither am I. I've never tweeted a thing in my life. Roger, that was really good, man. I enjoyed the heck out of that presentation. That was really good.
Well, thank you.
Yeah, and I'm going to be taking a trip up to Ithaca, New York,
Really?
in the very near future to see Craig and to meet your folks up there. And they're going to show me the meter on your bench, and then and your in your little sim lab, and then I'm going to hopefully be able to bring one home with me and hook it up to some patients, because this makes a lot of sense to me. You know, it's really, really good. Can we bring Roger back in, or while you're doing that, or? Everybody at home, and hope everybody's making, let's see, is it almost supper time? It's getting close. Mm-hmm. Okay, I see Roger over there. I don't see him over here, though, yet. So, tell me about your case.
It was a nothing case. It was easy.
It was an easy case?
Yes, it was just
so the
timing
surgeon was a little late?
Yeah, there's a little bit of a delay.
We have just dead air times here, so we need to. The surgeon can never be late, though, according to the surgeon that was late.
No, that's correct. That's what
Because
he
you
told
can't
me.
start without him.
Yeah,
That's right.
that's what he said.
Yeah, that's what he believes.
It was a lovely case.
Just good.
A little bit later. That's
How many jumps?
3.
Three jumps. Good. And are we anywhere close, guys, or because we could just do a question and answer if we're going to be this long doing it. I just wish I knew what was happening. It drives me nuts.
Well, why don't we start?
Does he need to unshare his screen? Does he need to?
He's on Skype, he's not sharing his screen.
Okay. See, okay, so do you want to just go on commercial and then figure it out? So let's go to, we're going to do that. Okay, so Roger, once again, this isn't a disaster, but it's, we need to figure this out. So why don't we grab a quick soda or something like that, or a beer or some tequila, and give us about 5 minutes, and we'll come back and we'll get all this technical stuff figured out. So quick 5-minute break, everybody, and we'll be right back, okay? Perfect.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, The inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
We're back. And welcome back, everyone. Now, can we put all of us on the screen so we can see everybody together? Hey, there we go. Look at that's perfect. I can't believe how perfect this turned out. The only thing is, Dominic, you need to just move to your right about 2 inches. That's it. Right there. You are dead center right now. That is perfect. So, Dominic, first time you've joined us, I'd like to do a standard introduction like I do with everybody that first comes. You graduated from Butler University in 1988 with a degree in zoology and pre-med. Where is Butler University?
It's in Indianapolis, Indiana.
Indianapolis, okay. And then you completed, you became an RT, a registered respiratory therapist, and practiced for about 5 years. Decided you wanted to be a perfusionist. You must have gotten some really bad disease from one of the respiratory patients. You graduated from the first class of the Cleveland Clinic and Ohio State School of Cardiovascular Perfusion program in 1995. I presented your student research project at the AMSEC meeting, I'll forgive you for that, in 95, which was given the award of the best first-time presenter. Well, that's good. You're definitely promising a lot then, okay? As well as the AMSEC Research Award for exceptional original research published in JECT and for work in a pumpless AV carbon dioxide removal in acute lung injury. In 2010, and that was in 2010, you spent about 3.5 years as a clinical specialist for a VAD company, starting their U.S. clinical trials. Which one?
Everhart.
Where? Who?
It was Everhart, the
Everhart,
Japanese
okay.
device.
Uh-huh. And
I think they're in Houston now.
Yeah, and you returned to full-time clinical perfusion in 2013 as a mechanical circulatory support coordinator at the University of Louisville, Physicians Department of Cardiovascular and Thoracic Surgery. You mainly focus now on adult clinical perfusion, ECMO, VADs, and adult clinical perfusion and MCS, mechanical circulatory support, and when required, pediatric VADs. So that's a really well-rounded, I think, bio that you have with a lot of good information. I don't know if you had a chance to listen to Roger's presentation, but I think these presentations, all of them really sort of dovetail together because all of the patients that we're talking about at the end of the day are sick. So before we get started on your lecture, which you're going to have to share your screen and stuff, can we put the next poll up? Oh, and everybody, I keep getting the thumbs up. If you haven't already done it, thumbs up, like, follow, whatever else. Love us on the Twitter, Facebook, LinkedIn, and YouTube. I have to keep telling you that, or they get mad at me over there. Okay, I got our next poll up?
Yes.
Okay. Oh, okay. So I all I see is please fill in the survey. What's the question?
No, I don't know what you have, but I see.
Yeah, it's up. I've already done it.
Oh, what is it? Can somebody read it? Because I don't see it up there.
Okay, so it says, does your hospital provide ECMO therapy to patients?
In patients, okay, yes.
And then how many ECMO procedures are performed at your institution?
Okay.
Who initiates ECMO? And who monitors ECMO at the bedside?
Okay, so make sure that you go on Slido.com, PerfWeb29, answer the questions submitted, and you can also ask questions on this. So, without any further ado, welcome Dominic Cappelletti, and I'm going to let you go ahead forward with your presentation at this point in time.
All right, thank you. I'll try and get it up on the screen here.
And thank you for doing this and joining us. We really appreciate it.
Oh, my pleasure. I always love to hear the sound of my own voice. So first I want to thank you guys for letting me talk. When I first got in contact with Joe, I guess I just thought I was going to be some talking head. I didn't know I was going to do a whole talk, but that's fine, and I'm glad to do it. For a couple disclaimers first, this is not a high technically challenging talk, just some of my ramblings, and I'm just a simple country perfusionist, so I hope I can live up to Joe's expectations of me. So I want to start out with a joke that one of my cardiovascular fellows told me before she graduated. She said, "How many perfusionists does it take to change a light bulb?" And the answer was 4, 1 to change the light bulb, and 3 to tell them how they would do it better. That's not really my purpose here. I just kind of wanted to give a different perspective on how our program is designed and run, and I always am interested to hear about how other centers manage their VADs and ECMOs and things like that. Sometimes you can take things from them, and sometimes things just don't fit for your program. So we're going to go through a little bit of a brief history of my internet research. Okay, how about now?
Is it up?
Yep.
Yep, perfect. Good
Okay.
deal.
So, all right.
And close your little window that show. There you go. Yeah, you got it now.
Okay, good. I didn't want to look at myself anyways. That was kind of frightening.
We can see you though.
Oh, okay. I'll try not to do anything silly. So we're going to give a real brief history of mechanical circulatory support, what I could gather from the internet without having to do much work in the library. Some of the indications for use, basically it's real sick patients that can't get a transplant or aren't going to get one in time. Some of the devices that we use, our responsibilities currently in use here in Louisville, and what I think are some of the future possibilities of MCS. So everybody pretty much knows what a VAD is. There can be an RVAD, an LVAD, a BiVAD. We can include ECMO as a type of VAD. Total artificial heart is a type of VAD. I think most places are kind of lumping that into mechanical circulatory support nowadays, which kind of puts everything in one group. It can include the cath lab, the CVICU, and now I've heard they're doing them in putting people on ECMO in museums and things like that. So when I look back at kind of a history of artificial organs and circulatory assist, one of the first ones that I saw that I found was interesting was in 1915, they used a screen oxygenator to perfuse isolated organs. Then in 1916, as we all know, anticoagulant heparin was discovered, kind of made everybody's job possible. And in 1928, what I want to point out is they relied on a compressible diaphragm to circulate the blood during organ perfusion. And a lot of the early devices, and probably some of the ones that may be in the future, also use a compressible diaphragm or a blood sac or something like that to propel the blood forward. So that was all the way back in 1928, almost 100 years ago, and we're still using that technology today, although hopefully a little more advanced. And then in 1934, Dr. DeBakey in New Orleans used a dual roller pump for the transfusion of blood. So as we all know, dual roller pumps are in use every day, probably on every heart-lung machine out there. And again, that was back in 1934. In 1937 was the first sighting that I saw that they used an extracorporeal assist device to substitute for cardiac function in a dog, and that was for a little over 5 hours. In 1952, the first arteriographs made of cloth were described. So I think these were probably the precursors to our outflow that we use on a lot of our devices now. And then in 1953, John Gibbon in Philadelphia used the first heart-lung machine for cardiac surgery. Again, I can't say that these are exact or there's the only ones, but these are the ones that I found cited in a review article. And in 1954, Lilly High used cross-circulation to perform an intracardiac repair. Then in 1955, there was the first meeting of the Society for Artificial Internal Organs, and that was in New Jersey with 67 members. In 1956 in Cleveland, they developed the first successful membrane oxygenator, still in use today. In 1957, they used a total artificial heart in a dog, keeping the animal alive for 90 minutes. And then the biggie is in 1957, they came up with kind of a manufacturable, disposable bubble oxygenator that can be used at different sites, not just in big research centers. So that's kind of where our profession started, and mechanical circulatory assist started. The first successful implantation of an LVAD was in 1966, again by Dr. DeBakey, and this was implanted in a 37-year-old woman. The story that I got from that was it was a post-cardiotomy patient. It was a paracorporeal external device. You see the picture of it here. These are the inflow and outflow, the compressible diaphragm and the pneumatic tube that drove it. she was weaned off of that, to the best of my knowledge, in about 10 days. LVAD is Bridge to Recovery in 1966. That was that lady we just talked about. And this blurry diagram here shows the where it was anastomosed to the left atrium and the subclavian artery. This beauty here was implanted in 1969 by Domingo Leata and Denton Cooley into a patient in Houston. They removed it 64 hours later when a donor heart became available. And if you look at it, to me, this looks like caulk or glue, whatever else they used to mash this thing together. These two little nubs here are, I think, de-airing tubes. So you look at what they had to work with and their ingenuity enabled to make this device, and it worked. You would not be able to get by with something like that in today's world, but it did work, and the outcome was successful. Oops. Thoratec PVAD, people are probably very familiar with. I don't think they're manufacturing it anymore, and I don't think you can get pieces parts for it, but I know it was a favorite of a lot of surgeons. The device worked great. If you look on the left here, you can see what we used to call the big 500-pound washing machine. It was their dual drive console, and this is what powered either an LVAD, an RVAD, or a BiVAD. And this shows a BiVAD patient here on the right. We used this for many, many years, and in 1985, I think Dr. Lehman Gray did one of the first successful bridges with a Thoratec BiVAD PVAD to a heart transplant. Probably wasn't the first, but it was probably one of the first in the early 80s. And Dr. Lehman Gray is how I got my start in mechanical circulatory support. Whether it was good news or bad news, he asked me, or pretty much told me, that I was going to start in their VAD program, and I've been there ever since. That was in about 1996. The Jarvik 7, which is one of the things I saw when I was in high school, and one of the things that kind of got me interested in medicine and surgery, although I didn't find out about perfusion until I'd been working as a respiratory therapist for a couple of years. It was a pulsatile pump. They did excise the native heart, and in 1982, Barney Clark was implanted with that as a bridge to transplant. He was supported for 112 days. I think he ended up succumbing to infection or stroke. Never left the hospital, as far as I know, or he might have been the one that went to like an apartment they had for him across the street. The Syncardia today is the modern day Jarvik 7. So that previous picture was the old style device. This is the newer one, looks a little bit more sleek and nice. If you look here, you can see that they have Velcro in the middle there. So they were able to change the relationship of these two pumps according to the PA and aorta and that patient's anatomy. To my knowledge, they have two sizes available now so that they can fit it into smaller patients. And they also have what they call a portable freedom driver so that they can leave the hospital and pull their driver behind them. I think it weighs about 25 pounds. The HeartMate XVE was one of the first devices that I used. It was electrically powered. It did have a blood diaphragm that was kind of compressed by a wheel. It's kind of a neat design, but you could hear it. It's big and it was noisy, and it wore out in about a year to a year and a half. So if you had a patient at that time, I think they were almost all bridges, and our wait time was usually about a year to 18 months for our transplant patients at that time. Some of them the device could wear out, and they would either have to be replaced or they would have to get a transplant. And you would actually see the dust coming out of the vent tube. And if you wanted to, you could send a sample of that dust to Thoratec, and they would measure the amount of a certain metal alloy in the dust and tell you if the bearings were actually wearing down. This is pictures of the devices that we are using or have used since I've been here in a Jewish hospital here in Louisville. The Thoratec Centromag we still use sometimes for isolated RVAD support, and it is our main pump for our ECMO patients. We did use quite a few of the Thoratec PVADs. Great device, worked great. We'd used several of the Thoratec IVADs, which was basically their implantable version of the PVAD. The HeartMate XVE was big for us for several years. We then moved on to the HeartMate 2. We did actually do several of the Aero Lionhearts, which was a totally implantable LVAD. If you look, you can see over to the right side, that big round plate, that is a compliance chamber for the air that was shuttled in and out to compress the blood sac. Over on the bottom left, that was the controller/battery. And up at about 10 o'clock, that was the tech coil where the external power supply was transferred across the skin through that tech coil. We used the DeBakey in probably less than 20 patients. I think we used several of their designs. They had 2 links for their outflow graft. And this pump actually started out, from what I was told, as a NASA fuel pump for the space shuttle, and then they moved it into the medical world. It was the only one at the time, and maybe the only one that I've heard of, that had a true flow meter. It measured a true flow. It wasn't estimated based on speed or power, and that's that white donut looking thing in the middle there. They had some issues with their controllers, but other than that, I think it was an okay device. I always got confused when I started out, when I go to talks and they talked about the generations of VADs. I got this slide from the Heart Assist company off their website. So their generation 1, they're calling those big, large devices, the XVE and the NovaCore, which I used when I first got here also. Those would not fit in smaller females or smaller males. Then we moved on to the axial flow pumps that you could put in a wider variety of patients, the HeartMate 2 probably being the big one. They're calling the 3rd generation the centrifugal flow pumps, your Levicors, your Ventrasis, and now your HeartMate 3. And then the generation 4 is the centrifugal pumps with basically no pocket. And I guess you'd have to consider the HeartMate 3 being in that group also. They gave themselves, I think, their own generation 5, which is the Heart Assist 5, which is the danger of taking slides from a company. But what I liked in another slide that they had was they showed the size and weight kind of decreasing over the years until now you've got your HVAD and your HeartMate 3 that are probably around 150 to 180 grams. The Heart Assist 5, which I've never really seen or used, is they say weighs 92 grams. But you can see the size and shape has decreased over the years. HeartMate 2 has kind of been the workhorse for many, many years. A lot of places implant it, and some places only implant that. It works on the Archimedes screw principle, and it has the sintered titanium surfaces. So if you remember back in the day, we thought everything had to be ultra smooth so that the blood wouldn't form clots on it. What they came to find out is that if you put this sintered titanium kind of coating on the surfaces of the device, the body will lay down a layer of epithelial cells, and that should make it less thrombogenic. So they took that technology that they had in their HeartMate XVE and put it into their newer devices, the HeartMate 2 and the HeartMate 3 devices. I think the last count I saw was 20,000 patients or more had been implanted with the HeartMate 2 all across the world. The Heartware HVAD, which we've been using since probably 2009, 2010, their initial clinical trial, is a good device also. It's a centrifugal pump. The newer ones now, a lot of them are moving to integrated or integral inflow cannulas or conduits that are integrated into the pump. What I want you to notice on this one is this a picture of the old device where that inflow portion was smooth. It's now got that rough surface to kind of promote the tissue ingrowth and the layering down of that epithelial layer of cells. Something that's kind of near and dear to my heart is the AbioCore. Not around anymore as far as I know, but there was a lot of research done on it in Houston and in Louisville to get this implanted in patients. It's a total replacement heart. It was totally implantable. It had an internal battery, an internal controller. The internal battery, I think at that point would last 30 minutes to an hour, where they could go totally untethered, swimming, take a shower, do whatever they wanted to do. It was a very complex device, probably one of the most complex devices for its time. And we did about 50 or 55 animal implants, large animal implants here in Louisville at our research institute. And our surgeon decided that he wanted the same team involved in the animal research as he did in the humans. So when we started doing these large animals, mostly cows, he brought over the scrub nurse, the circulating nurse, the surgeons, 2 surgeons, 2 perfusionists. So the same team that did those 50 or 60 cows was the same team that went across the road and did those 7 patients that we did in Louisville. So it was kind of a neat thing. It wasn't lab people doing the surgery. It was actual human clinical people. So we had a lot of experience putting this device in before we did our first patient. First patient, I think, was done on July 2nd, 2001. He lived 6 months. I don't think he ever left the hospital. Part of the reason is when the FDA first allowed them to do these implants, the patients had to be very, very ill, even more ill than probably they would for a normal LVAD. So we were fighting a losing battle pretty much from the beginning in that they had a lot of times what ended up being irreversible end organ failure. So a lot of them didn't do that well. The patient that lived the longest, to my knowledge, was a patient that was implanted here in Louisville. He lived about 18 months, probably 12 or 13 or 14 of those months was at home. He got to go to weddings. I think he celebrated 1 or 2 Christmases and a lot of grandkids events while he was on that device. Eventually, after about 17 or 18 months, those blood sacs in there kind of started to stretch. And when they stretched, they started to impinge on the motor or the valves inside of the device. And the company was aware of this, and they must have informed the patient that his device was heading for failure. And rather than having his device implanted or reimplanted, he decided that he'd had a good long time on it. He'd got to do some of the things he wanted to do. So he opted to come into the hospital, have a nice lunch with his family, and just let the batteries run down. So he got to kind of choose the end, how it happened. His pump just didn't just seize up at home while he was playing with his grandkids. So it was very sad, but very well controlled, and it was nice for him and his family. So this is a little bit about the patients. Dr. Lehman Gray and Robert Dowling did the first one in 2001. It was an incredible effort. Unfortunately, it didn't pan out, but we learned a lot from that, and I think other companies have learned a lot from that also. The HeartMate 3 is the one we've started using for a couple years now. It's a centrifugal magnetically levitated pump, and the HeartMate 3 and the Heartware both have artificial pulse modes built in, which is a little bit of a misnomer. It doesn't generate a pulse that you can feel. It generates what they're calling almost a micropulse, where it speeds up and slows down so many times during a minute for a certain period of time. What they hope will happen is that it might help with some of that microcirculation issues that people get in their guts, as far as the von Willebrand factor deficiency and the AVMs and GI bleeds that these patients sometimes develop. So why do we need them? Millions of Americans suffer with heart failure, and these are statistics from 2013. So it's probably more than that now. The cost is the big thing. These patients are in and out of the hospital for many days at a time, 5, 6, 7 times a year. Excuse me. Their quality of life is not great when they're home, and medical management doesn't fix all of them. So end-stage heart failure is a chronic terminal disease, and what do we do when medical management no longer is working? We try and put VADs in them. In Louisville, we've been doing VADs here since, like I said, the mid-'80s. They've been doing research on VADs at our research institute probably that same amount of time. So companies will come here and they will have part of their development and animal testing done here in Louisville, because we do have a large animal lab. We've implanted over 10 different types of devices that I can count and remember and think about. I've noticed over the 25 years I've been doing this that the size has considerably reduced, but what's even more important is the durability and overall functions has considerably increased and improved, so we can put them in more patients, smaller patients, and they're pretty much plug and play. And the patients don't really have to do much with them at home, and they're pretty much trouble-free for the most part. So our team here, again, it all started with our cardiac surgeons back in the 80s and has continued on. Our main LVAD surgeon now is Dr. Mark Slaughter, who came to us from Advocate Christ, I think in 2008 or 2009. He's heavily involved in research and trying new devices and putting patients on support. We have a team of heart failure cardiologists, but again, a lot of it is perfusion different, which is not rare, but I don't think it's the norm. So like I said, I think programs start, when they start, they kind of choose who they want to do what. And for whatever reason, our surgeons were very pro-perfusion. They had a lot of faith and trust in their perfusionist, and they felt with their training and background, they were the perfect people to learn these devices and take care of them from beginning to end. So we have a team of 5 perfusionists that are our core VAD team that does most of the VAD work and MCS work at our hospital. We have a total of 9 perfusionists plus 1 dedicated peds perfusionist, but the 5 of us are trained and extra trained and take care of these patients every day. Pretty much almost anybody in our hospital can come in contact with a VAD patient. I think now we have about 120 on support, and most of them are home now. I think our inpatient population now is 7 or 8, and that varies per week. Our VAD nursing coordinators are great. They are our gatekeepers. They manage more of the medical side of it. We manage more of the technical alarm equipment side of it, but all the calls go through them, and then they decide who needs to be called to help take care of that patient after that. We have nurse practitioners that are both working in the surgical part and the heart failure part. And again, you see all those other people listed down there. We meet every week to discuss patients that we're going to implant or patients that we've already implanted to decide what the next course of treatment is. So our duties here at the hospital, we have directors of both the ECMO and the VAD programs. For ECMO, we do the initiation, the decannulation, 24-hour alarm and troubleshooting, maintenance, ordering, and tracking of the equipment. We do sit ECMO for the first 6 to 8 hours and PRN after that. We round on them twice daily during the week and once on the weekends. We consult for the cannulation, parameter, and weaning. We do all the training and competency evaluation of all the staff and usually anything else they can think of. So one of the ways we've been able to, I think, get away from the bedside, and this is a discussion that probably take a lot longer to talk about it as far as our ECMO program, but we spend a lot of time and resources training our CV-ICU nurses. We retrain them several times a year, and also we have a very simple setup, which makes it, if they don't pull it out, there's probably not a lot they can do to compromise the system. As far as the MCS, we're involved from the beginning to the end with new devices, old devices. We do all the device prep and console management in the OR. We transport all the MCS patients throughout the hospital if they need to go for a procedure. One of our main duties is keeping us certified with JCO. Our chief does the documentation, keeps up with the compliance and preparation for our audits also. Why is it not going forward? Okay. All right. We also educate all the staff. That includes the physicians, nursing, ancillary staff. We train pre-op, post-op. We train the nurses on the floor. We do education for our PT/OT departments. Pretty much anyone that comes in contact with a VAD, Perfusion has some role in helping to train them. We also do the yearly nursing competencies along with our VAD coordinators. We provide education updates. We also go out into the field to train first responders, dialysis centers, short-term, long-term care facilities. And again, we do the device tracking and equipment change-outs. So everybody knows how LVAD works. It has a controller that's usually powered by 2 batteries or a battery and an AC adapter. These are just the HeartWare 2 or the HeartMate 2 and 3 controllers. The types that we have right now, for the most part, these are the three or the two or the three main ones that are non-pulsatile. Most of the total artificial hearts that are being developed, I think, are going to be pulsatile devices, but that I'm not sure about. So they all have a speed that's set by the surgeon or the cardiologist. The flow is almost always estimated, and we measure the power in watts. For the most part, they're all anticoagulated at our program. Most of them are worked up to a full aspirin a day. Every now and again, we add platelet inhibitors. Coumadin is the main drug for the INR goal of 2 to 3. That's flexible depending on the device and the patient. And pharmacy helps us with dosing that in the hospital. And the VAD coordinators and cardiologists kind of dose it when they're at home. Some of them have home INR machines, and we monitor it that way. Every now and again, due to recurrent GI or nosebleeds, we have to markedly decrease or discontinue anticoagulation. But we don't like doing that. You're kind of playing with fire there. External VAD equipment, just some pictures if you're not familiar with it, of the heartware on the right and the heartmates on the left. Now the ugly part is the driveline. It's one of the things I think we need to get rid of if we're going to be really comparable to transplant in the future, because driveline infection can really take a patient and knock them down and keep them in the hospital. So we try and fix our drive lines in two spots, once where it exits the body and once again a little further away. So if they do drop the controller, these anchors or tape will take that strain and it won't tug on the actual exit site itself. Our coordinators kind of score the drive line exit site, 1, 2, 3, and 4. That way everybody's kind of talking the same language when you're describing what their exit site looks like. And we try to get to them and treat them when they're at a 1 or a 2. Once they start getting down to the 3 and the 4, then you're talking multiple driveline debridements, long-term antibiotics, and eventually the infection will probably take them. So I don't think I look anything like this guy on the right, but one of my lovely coworkers sent me these two pictures together and thought that I should use them for my profile picture, but I know I don't pull my pants up that high. So complications with LVADs, bleeding, thrombosis, hopefully not neurologic dysfunction or infection. Hemolysis can still be an issue from time to time. Device failure is really, fortunately, fairly rare. What is a little bit more common is worsening right heart failure and aortic valve insufficiency, which I think is just a part of their natural disease progression over time. But we try to keep an eye on that and minimize it when we can. So what do I think the future of it is? Total artificial hearts, certainly. Transcutaneous energy transfer or charging or powering the VAD across the skin. That technology has been around for a long, long time. It is just not translated into VADs right now very much. Totally implantable artificial hearts and totally implantable LVAD and RVAD systems where we don't have a drive line is going to be the next big thing. There's companies I'm sure that are working on it. To be able to do that, I think we have to have long life implantable batteries. The ones that I've used in the past would last about a half an hour and needed to be replaced fairly simply after about every 6 months to a year, probably about a year. Systems need to be durable. We need to make them last 10 years or more so that they can be comparable to a heart transplant. If we improve the blood contacting surfaces, that'll allow us to limit or get rid of anticoagulation, which would be great for a lot of these patients. There are some minimally invasive surgical implant techniques out there, but we need to make those more widespread and transfer them into some of the different devices to make the surgeries a little bit simpler and a little less invasive. So I went to look to see what devices were being developed out there, and again, you can't find a lot of information because they're trying to keep their technologies secret. But both of these, to me, look like they are biventricular support, the real heart and the bivacor. The CarMat has been implanted in patients in Europe. I've heard rumors that they are going to start a U.S. trial. I don't know when. I've also heard rumors that Louisville will be one of their clinical sites, but that's all unsubstantiated rumors at this point. I like these two pictures because they're both small biventricular support devices. And this one, if we look on the bottom left, that to me looks like a small tech coil. So this one looks like it's an implantable, totally implantable device. So what's it going to take? A lot of money. It's going to take some time, and the companies have to commercially commit in order to bring these devices to the patients. We got to get a little bit lucky, and the FDA has to be able to be a little bit more, how am I going to put this? It's got to be a little bit faster and a little bit cheaper to bring these to market, and the FDA has a lot to do with it, but they have to be able to do that quicker and cheaper without compromising patient care. And I'm not sure I have the answer to that. So I like this first quote. Just because we can doesn't mean we should, and that translates to everything in medicine. ECMO, VADs, you could put a VAD or an ECMO on anybody, and you can probably keep them alive, but it's not always the best thing for that patient. Sometimes we need to look at the end goal and see if we can get there with what we have. Dr. Bud Frazier mentioned this in a talk of his. I don't know if it's his for sure, this quote, but success has many fathers, but failure is always a bastard. We always want to take credit. Everybody wants to take credit when things go well, but nobody wants to be in the room when things go poorly. I think you have to kind of do both. This is my quote. There is a noticeable difference between engineering science and medical art. I thought about that when I was trying to talk to the engineers at the VAD company that I worked for, and everything with them was black and white, and I don't think medicine is really all that black and white. There's some art and some nuance to it, and especially when it comes to taking care of VAD and ECMO patients. There's not algorithms for everything with these patients. So thank you guys very much. Let me unshare my screen. Let's see here.
Okay, and welcome back. So we got the screen unshared. I think I'm back. Roger, thank you so much. Can you bring us all up so that I can make the quick announcement and we can keep moving forward? There we go. I got two. Got almost there. Okay. And so, oh, he needs to unshare. Oh. Okay, so what we're going to do is, Roger, thank you so much for being so patient, and Dominic, both of you exceeded my expectations. We're going to go to another quick break, and the guys are going to, I think, cut the feed, reconnect, and bring Dr. Murtha in from Amsterdam for our final talk, and then we can all have our discussions. Is that what you want me to say? Okay, very good. I did it. Okay, so thank you all. Just be patient. We're going to disconnect and come right back on the Skype thing. The viewing audience will still see us, and we're going to get Dr. Murtha on the screen next. So be patient. This is the first time we've ever done this. We've got 3 Skypers, one from Louisville. Roger, I forgot where you are now, Indiana, and somebody from Amsterdam all at the same time. So few-minute break. We'll be right back. Are our mics off?
I don't know, I'm putting mine on.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Welcome back, everybody. Okay, so this has been quite an adventure, and we actually have now Dr. Mathura actually on scene as well. So can we go to those three? There you go. Okay, so what do we have to do? Let's see. Roger, you need to move left just a teeny little bit. There, a little more. There you go. Perfect. Okay, everybody is perfect. Dr. Mathura, thank you so much. I understand it's midnight where you are. Is that correct?
That is correct.
Yeah, that is quite late. Thank you so much for staying up and doing this. But you know, let me quickly go over your bio, and then I would like to also take a minute and do something else, because I did some research on you to find a little about you. But you graduated with a degree in medicine from the University of Amsterdam.
Correct.
You have a PhD in research with a professorship. I can't say that, at the Department of Clinical Physiology at the University of Amsterdam Academic Medical Center. So you're an early care investigator pushing the relevance of the microcirculation into clinical practice. Now you went to medical school, but you actually decided not to practice as a physician, and I guess your heart was more into research, and you focused really on this microcirculation. And it was interesting because if you listen to the last talk that Dominic gave, he talked a little bit about the microcirculation. And that's going to be one of my questions later. But moving on from there, you have published a lot of articles in several journals, including The Lancet, Applied Physiology and Critical Care. You're one of the founders of Microvision. I think you're the chief science officer as well. You work closely with critical care leaders to develop microcirculation monitoring as a viable tool for clinical decision making and support, and in charge of an initiative by Microvision, your company, Medical, to help clinicians set up clinical investigations and publish their results in acclaimed international medical journals. So that's your bio. I'm fascinated by it. I've thought about it for years. I think I talked to you on the phone about this idea of a macrocirculation and a microcirculation that exists, and that we understand the microcirculation is there, but it's kind of out of sight, out of mind. We see a blood pressure, we see a filling pressure, we see a cardiac output. We focus on that because that's what we see. And so I think this is going to be very interesting indeed. But I wanted to bring this up as well. David, can you throw up that other thing that Dr. Mathura is involved in? We're going to talk about this. So we noticed that you were a senior instructor in the pranic healing. And I read a little bit about it, and everybody can take the time to read that right there. And you and your wife both involved in this, as a matter of fact. And being a senior instructor is actually pretty high up in the chain. I think next would be master. Hopefully you'll achieve that level. But I thought it was very interesting, the whole concept. And I thought people would be interested in knowing that, you know, you have these other interests beyond just the normal thing, more of a holistic approach towards our life and how we live and survival and everything else. And I think it goes hand in hand with what you're doing there in Amsterdam with Microvision Medical. So so we're very interested to hear your presentation. One second.
Next question, Paul, I open.
Next question?
The polls.
Questions, the polls.
No, we're going to do it at the end.
But you have to say you have
and the
questions so people know.
Oh, yes. Okay, so the poll questions will be open. So please go ahead and you can go to the poll and answer your questions and so forth. And then we're going to review all of the answers and all of the questions that have been presented already later on at the end when we're in the discussion period. So Dr. Murta, once again, it's a pleasure, it's an honor, and I appreciate all of you that are here, Roger, Dominic, and Dr. Murta, especially for staying up past midnight. It's already midnight 19, and your poor wife is probably sleeping, or either that or she's reading or she's studying pranic, because she's probably very upset with me right now for keeping you up so late.
No, she's fast asleep, so because she has to teach finance tomorrow.
Oh my goodness! All right, well, we'll try to get through this. So, if you'd like to go ahead and share your screen, and then we will move forward with the presentation.
So let's see. That should be the presentation right there.
Perfect.
Okay. So thank you for having me. It's a real joy and no effort at all to stay up this late. So thank you for the introduction. My topic is today the microcirculation, and of course, as measured using our technology, which is the microscan. So let me just give you a little bit of background. Probably when you were in medical school or when you were studying, this is what you saw. We had these big microscopes that did the measurement of the microcirculation on the nail fold of the finger, and then we would see these tiny little loops through which the red blood cells moved, and basically that was it. And these are still in use in most major hospitals for monitoring of peripheral perfusion in diabetics and stuff like that. So when I got into research, I did it with the Department of Physiology, and then we kind of figured out that, okay, we can miniaturize the whole thing. The inspiration for that was an American company, actually, called Cytometrics, and they developed this little tool to measure the microcirculation, and they actually wanted to use it to do some other things, like measure hemoglobin. Well, that's actually technically not feasible, but we basically got the idea that, hey, maybe we can miniaturize the whole thing. So that resulted in a better way of doing it, which we called Sidestream dark field. And with it, we can just visualize the red blood cells. We do that by using green light, which is absorbed by the hemoglobin in the red blood cells. And then you see the red blood cells moving through the capillaries and the arterioles and the postcapillary venules. Quite nicely, and then of course you need a piece of software to translate that image into a number. And we're currently at the second generation of SDF, which is now connectable to a tablet or a laptop with some sophisticated analysis algorithms behind it, so you can get a number fairly quickly in a few minutes to do the measurement at the bedside. So that is about the technology, and this is why we measure sublingually, because actually it's fairly close to the aortic arch. The sublingual artery or the lingual artery branches off fairly quickly, so it gives you quite a nice window in what is happening in the rest of the body. So for instance, if you see this was an animal study, and they made these animals septic by cecal ligation and puncture. And what you see here is very nicely that as the animal becomes septic, you will see very nicely the microcirculation of the gut follow, or the sublingual microcirculation very neatly follows the microcirculation of the gut. So they had one microscan on the gut and one microscan sublingually, and they follow each other very nicely. So what we know is that the sublingual microcirculation mirrors quite well the gut microcirculation. So it really gives you insight in, okay, what's happening in that level of the body. Now, this, of course, you probably know already, but basically we look at this compartment right here. And that looks something like this. So what you see here is you see very nicely the dots of the red blood cells moving through these blood vessels. So these are postcapillary venules right here. And here you have a nice arteriole. And then in between, you have these nice capillaries in which you see single red blood cells moving through. And what we also can see in this image very nicely is some white dots flying around. And these white dots are, of course, the leukocytes. And what is interesting, this is actually my sublingual microcirculation after an intercontinental flight. And what you see is actually more white blood cells than I would normally see in my microcirculation. So there are actually quite a few here. We've been doing some work lately to quantify that, but it's not as easy as it looks. So we're still working on that. But this is basically how a healthy microcirculation would look like. And if we then look at some examples, our earlier work tried to classify the different phenomena we were observing. This was before we had software that could rapidly give you an assessment. So we kind of divided it into completely stagnant images or images where you had flowing capillaries next to non-flowing ones, images where you had start-stopping phenomenon, or even hyperflows where it was the blood flow was so fast that the camera just couldn't pick it up. Now, the second generation microscan has a high frame rate camera, so that hyperdynamic thing is actually less of a thing, but I will show you what it looks like. So, for instance, this is pretty much what we call a stagnant image. So what you can see here is actually in the capillary. So this is actually capillary. You see single file red blood cells, and they're just completely stopped. Then, of course, in the deeper layers of the sublingual mucosa, there is some flow. But on the whole, you see these red blood cells just not doing anything, and then a few ones in the background where there is flow. But this is a very, very poor outcome image. If you would see this in a patient, then there's something really, really wrong. And we know that if this image stays like this for a few hours, this patient will most surely die unless you do something different in what you have been doing. And we'll get to that later. So this is where you see areas of non-perfusion. So, for instance, you would expect red capillaries in this area, you would expect capillaries in this area here. And actually you can't see any. If you look very carefully, you see some single red blood cells flying around here. But on the whole, you've got flow, even flow in capillaries, next to areas where there's just not much happening at all on the capillary level. The larger vessels are preserved. But on the whole, this is a very poor image from a capillary perspective. There are very few capillaries here. And this is what you generally see in patients that are on the ICU or that are post-surgery. This is the image that you will get. So the larger vessels, the flow is preserved, doesn't look very bad, but on the capillary level, there's something off. They're disappeared, they're not perfused, and the ones that are perfused quite poorly. And what you then usually see is that there are areas where it's very poor. Right next to areas here, you see a few capillaries. They're very, very they're very big. So there is some dilation going on here. So you have areas with no capillaries and areas where you see capillaries and they're actually normally perfused. So it's also the heterogeneity of the image that really is striking for this type of patient. This is another example of what you will see regularly is areas where there's poor perfusion next to areas where the perfusion is actually quite normal. And even on the capillary level, there is perfusion. Right? But here, for instance, you see the capillaries, there's hardly any perfusion at all. And again, in the larger vessels, the perfusion is more or less preserved. So most of the time, unless the patient is doing very, very poorly and is really going towards depth side of things, you will see this image. So you see flow next to non-flow phenomenon. And when you analyze the images, you will see that on the capillary level, the score is actually very poor. And this is just an example of very fast flow, or what we categorize as hyperdynamic. So you can see these red blood cells moving very, very rapidly through the capillaries. And we actually have, this is what you will see sometimes with ECMO or other extracorporeal circulation devices, where the red blood cells really are racing through the microcirculation. And we kind of had many discussions with physiologists that, okay, how fast would these red blood cells need to flow before offloading of oxygen becomes impossible? But yeah, we could not reach consensus with them, so we still don't know whether this is of physiological importance or not. But it was an interesting discussion nevertheless. You know, are these red blood cells now capable of offloading the oxygen and absorbing the CO2 properly when they're moving this fast? And this is another example, even faster. You can see that the flow is so fast that actually the camera can hardly pick it up. Mm-hmm. It's thanks to the white blood cells that we can see something moving, otherwise it would just look like nothing is happening at all. It's so fast the camera can almost not pick it up. Again, with the newer generation of SDF, this is not a problem anymore. But just to give you an idea of what it looked like. Again, this was an ECMO patient, if I'm not mistaken. So when we look at the microcirculation, of course, a capillary is defined as having a diameter of about 7 microns. But when we look at the microcirculation sublingually, we can give it a bit more space, a bit more broad definition of 10 micrometers, because we see that as white blood cells move through those capillaries, they are actually extended for a few microseconds, so that if you measure the red blood cell column behind it, it's actually a little bit more than 7 microns. And then after a few microseconds, when the white blood cell is passed, it returns to that 7 micron-ish diameter. So we kind of define it as 10 microns or less, and that is actually also what most physiologists will say is a proper definition of a capillary. Then we said small vessels, which are mostly the postcapillary venules. The medium vessels are the larger venules, and then we have the large vessels, which are, for most intents and purposes, not really relevant for any prediction or anything like that, because most of the time they're preserved. So the most data you will find in the capillary level and the small vessel level. That's where the data is. That's where you find your distinguishing parameters. So back in 2006, when we just launched the product, we actually used, together with very leading investigators, clinical investigators in critical care. One of them was Daniel de Bakker of Brussels University Hospital. He basically used a method used in pathology. He just drew a grid, and every place where a vessel crossed the grid, he would count it as small, medium, or large, and say, does it have flow or not? And then you will get a score, and he will use that score to calculate a perfused vessel density, which is the total number of perfused vessels divided by total, or perfused small vessel density, which is the total number of small vessels perfused divided by total of small vessels. And now with the software, we can even give you a perfused capillary density, but it's basically the same thing. But this was the time of manual analysis. 2006, it was a round table. 2007, the paper was published. And this is basically the first steps into, okay, how do we do this clinically? So now we have automatic software that does this. And if you look at literature, basically A healthy person will have a proportion of perfused small vessels, so that includes the capillaries, so anything smaller than 20 microns. So a healthy person will have a score of 95% or higher. So 95% of those small vessels have flow. Then there's an unhealthy category, which is 80% to 94% of small vessels that have perfusion. And this is a danger zone. So this is where you need to start monitoring more closely. You need to keep an eye on patients that have this. And then the real danger zone is when the proportion of perfused small vessels drops below 80%. Because several papers show that if that number is lower than 80% for about 24 hours, those patients will surely die. So that is established beyond doubt, that this number is really the lowest you can have it before things really start going wrong. And that has a very logical reason as well, because the less capillaries you have, the greater distance between one capillary to the other. So, and there is a maximum perfusion distance diffusion distance of oxygen through that tissue to the cells. So if there are less capillaries, the distance between capillaries just becomes too large for cells between them to get oxygen diffusion going on, and they will start switching to lactate and then eventually dying off if that state is preserved for too long. So this proportion of perfused vessel, you can translate in your mind as, okay, I need a minimum distance between capillaries for all these cells in between to have enough oxygen. That's the basic idea behind this number. So if you look at ECMO, for instance, there's a nice paper in 2017, and I see that one picture is off here. But what we see is that they tried weaning patients from ECMO, and when the patients, so they just dial the flow back to 50, so they have the flow, and if the microcirculation is then preserved, they can be successfully weaned off. And if the microcirculation is not preserved, then you see actually a drop in this case, total vessel density, so how many vessels are visible per image. And an image is about a square millimeter. So that image should be here, but basically what you see is if you reduce it to 50%, you will see a drop in that vessel density, and then if you dial it back to 100 again, then those vessels come back again. And then you know that, okay, this patient is not ready for weaning again. Again, this was a very small study, but also a very powerful study because it shows very, very clearly the importance of the microcirculation in this whole area. And another study a year later, so this was this group actually in Rotterdam. One of the authors of that group was actually a Taiwanese person, so that person went back to Taiwan and did a bigger study with 246 patients. And what they showed actually is that the score on T is 0, so when you start your ECMO support, actually tells you something about how that patient will be doing later on. So it was very, very interesting. We don't really know what to do with this yet, but you can kind of sense that, okay, if the score is poor at the beginning of ECMO and it doesn't improve very much, then the outcome will also be very, very poor once you wean them off, if ever, which is kind of what the results showed, that the patients whose microcirculation remained poor during the whole ECMO support, they pretty much died. So that was a very, very interesting outcome. And what they suggest is actually, well, you know, maybe we should use this microcirculation parameter as a, okay, maybe we should do something different while the ECMO is on to make sure that microcirculation improves or the capillaries are recruited. most of the work in this field has been done in sepsis. So I just want to go through a few slides in sepsis so you get an idea of how it's being used at the moment. So this was the breakthrough study back in 2004. Again, this is Dr. De Bakker's group in Brussels. And what they showed is, okay, there's a marked difference in the perfused small vessel density of survivors and non-survivors. And so the PPV, the proportion of perfused vessels, improved in time for survivors. It went up, and it did not in non-survivors. So it stayed around 60%. And that was, of course, a complete new revelation to everyone in this field, saying, wow, is it really that easy? So, of course, then you see a lot of people repeating the same study. And again, this is a study done in the US, in New Jersey. The lab of then Steve Hollenberg, who moved to Virginia later on. Again, survivors, their microcirculation improves. Non-survivors, their microcirculation does not. And then a bigger study with 531 patients in 36 ICUs in all the world. They saw that, okay, a poor microcirculation, so PPV of even lower than 90, so that's still pretty okay, was observed in about 17% of the patients. And if that PPV did not improve, those patients had a higher risk of dying than the patients where it did improve. So then we have more and more studies proving the same points. I just won't bore you with that. I will send the slides to Joe so he can distribute it to you guys. But basically, pretty much same thing over and over again. Poor microcirculation, poor outcome. And this is the most recent one. It was just published in European Heart Journal on cardiogenic shock patients. And that was very interesting because they showed that the microcirculation was highly predictive of mortality and renal replacement therapy in patients. So if there were microvascular problems, those patients had a higher risk of renal replacement therapy and dying than the patients without it. And this is a multi-center European trial, which was part of a bigger study called the Culprit Shock, which is a huge study of hundreds of patients in about 15 European centers on cardiogenic shock. So this was a small sub-study, but very powerful results. So this is the most recent one, again showing the same results. Now, what is also interesting is that this microcirculation, the dynamics of it are actually independent of your global hemodynamics. So mean arterial pressure, lactate, O2 gap, CO2 gap, all of these things, they are pretty independent of what the microcirculation does. So we monitor all these global hemodynamic parameters because why? We want to get oxygen to the cells and we want to get CO2 away from the cells. And we think that, okay, for instance, if the mean arterial pressure is good, then most probably the microcirculation is okay. And it turns out that it is not. So this study in 2009 shows that even though all those global hemodynamics, if they are in the green, then still you can have a poor microcirculation. And it turns out that if the microcirculation is poor at baseline, so at T is 0, it is most likely to be poor later on as well, even though you correct all these hemodynamic parameters. So that was very, very important. So in this case, it was done with mean arterial pressure. Here we have similar, but then with fluids. If you do fluid therapy and the microcirculation improves, these patients do well. If you do fluid therapy and the microcirculation does not improve, then these patients do poor. And this study also figured out that, okay, If you give the fluid therapy early, the chance of improving the microcirculation is higher than if you do it later. Well, that kind of makes sense to everyone, but yeah, now we have it in a proper study. Here we have a study where they show that if the microcirculation improves, the SOFA score also improves, which is, of course, a given. But what is interesting is that the SOFA score might not improve if you improve your global hemodynamics. So again, this microcirculation is a very, very good guideline or monitoring technology to give you an idea of what's actually happening on a cellular level. Again, same thing. If you give fluids, you improve the microcirculation, and the outcome is better. This one is late versus early, and of course, early fluid resuscitation gives an earlier improvement in microcirculation and thus a better outcome. So again, same thing. So what does it all mean? Well, what it all means is that we have a cardiac output, we have a mean arterial pressure, sometimes we have a central venous pressure, but what we really need to know is what happens here in the microcirculation. So if we add that piece to the puzzle, then the puzzle is complete and we have a complete picture of what this patient is doing. And what we can learn from literature, and which is a greater body of what I just shown you, is that basically you will do the same thing. You will use fluids, you will use vasopressors, you will use inotropes. You may even use vasodilators to increase the flow in the microcirculation to recruit capillaries back to their normal function. But one, you need to start it early. Well, that's a given. You should have a goal of about 80% for these small vessels. We also know from literature that a higher central venous pressure is not always better. So it seems that there is, so that 500 plus patient study in 36 ICUs showed that patients with a CVP above 12, they generally had a poor microcirculation. And the idea is that most likely the pressure in the venous compartment is too high, thereby thereby basically pushing back the red blood cells into the capillaries. So if you lower the CVP, the pressure in the capillaries can overcome the pressure in the postcapillary venules and thereby facilitating flow, offloading of the capillaries into the postcapillary venules. So we need to be really careful with that central venous pressure, or the pressure in the venous compartment. And the fourth item is we need to make sure that if you increase the mean arterial pressure, so if you give catecholamines, better make sure that it does really improve the microcirculation. So you can do the intervention, but then immediately check the microcirculation. And if the microcirculation does not improve, you may want to not go for increases in mean arterial pressure. And actually, we've spoken to many cardiologists who say, well, you know, if the microcirculation is okay, we even accept mean arterial pressures as low as 40, as long as the microcirculation is okay and we see signs of urine production. So that is a slightly different paradigm than most physicians and especially intensive care physicians would use. And the fifth part is also be careful with increasing cardiac output. Increasing cardiac output is not always good for the microcirculation. It may be good for other things like urine production, but you might not always increase your microcirculation. And then you need to figure out that, okay, if I want to increase the cardiac output, do I need to do something else that helps recruit the microcirculation, like give extra fluids or lower the CVP, or maybe even give vasodilators to make sure that the pressure in the venous compartment is not too high, or that the the increase in cardiac output is not caused by a squeezing off or shutting down of capillary perfusion in favor of pressure, because that is what happens or what can happen. So these are some of the things you could consider while looking at the microcirculation and treating your patient. So that is in a high-level view of what you can do with microcirculation therapy and perfusion.
Wow. I'll tell you what, these have been three of the most, I'm going to give that an applause. These have been three of the most informative lectures I've listened to in a while. Can we throw those guys up? Oh, as soon as Dr. Murtha, if you could stop Mathura. Yeah, there he did it.
Dominic dropped off. He got disconnected.
Oh no.
Try to connect him again?
Yeah, please. So, Dr. Mathura, if I could indulge you, so I would consider, because I've heard this a lot in the critically ill patient, I've read a lot about drier patients tend to do better. And I was listening to you talk about the elevated CVP, and we frequently see that. That's very common. So I coined a phrase and see if you agree with it. Increased preload becomes capillary afterload. So, you know, we think about afterload of the heart.
Putting it.
Is that good? Is that a good one?
Yeah, that's a good one.
You can use it.
I may use it.
Yeah, please. Yes, yeah, please. I haven't trademarked it yet.
Okay.
So could we throw Dr. Murtha up so that he's on the screen instead of me?
Yeah, I'm trying to get Dominic back.
Okay, yeah. So let's do that. So Dr. Murtha, while they try to get Dominic back, we're going to go to the polls. Let's go to the polls and see what we got. And then I think there's a section on there too for questions so that we can address those as well. Excellent talk though, everybody, by the way, and we really appreciate this so very much.
It's fascinating.
It is fascinating. Well, you know, I mean, I read the articles that you had recommended that I read, and you know, I was sort of, you know, it seems very encouraging, and I see the utility. But, you know, conventional medicine is so difficult to steer in a different direction.
Let's do that. So, Dr. Murtha, while they try to get Dominic back.
What's up?
I'm
listening to myself.
To the polls. Let's go to the polls and see what we got.
Oh, somebody, you need to turn the volume down.
There's a section on there, too, for questions. So that we...
Hey, it was Dominic.
Yeah.
Dominic, you got caught. Okay, so can we put them up on the screen instead of us?
Yes. One
Yeah, we'll deal with that once we get them up, because then I can see them. There you go. And Roger, to your right. A little more, just about an inch. There you go. Perfect. There you go. Perfect. That was great, guys. Okay, so we have lots of questions, and instead of putting them up, can I just see them on my phone somewhere, or can you just give them to me so that I can look at them? So we've got a bunch of questions. Roger, you know, I think that those flow dynamics that you showed with your that study that was done, where they looked at how the blood goes in circls and swirls and doesn't get to where you need it to get to. How closely do you think this device, this ELSA meter, how closely do you think that really gets to being able to fine tune this? Notice how often can you do it and be able to get a number that for you is meaningful?
Most of the intensivists like to get it every 8 or 12 hours, maybe every 24, until the patient acuity gets to be a problem. Or, you know, if the patient's mobile and they're moving around, perhaps they're getting a lot of excursion from a ventilator if the vent's on. If they're suspicioning that position is a problem, or they're just not getting the numbers that the patient condition seems to warrant, then they can run it as often as they want. instead of shooting a film before and after moving the cannula, they could give a simple saline bolus and adjust it that way. So as long as the patient's IOs are okay, there's, especially if they're on CRRT, there's no real reason, no limitation not to give a small saline bolus.
Mm-hmm. Yeah, I agree. So, and you're talking about what, 10 cc's?
On a little guy, it could be as small as 5. On an adult, up to 20.
Okay, good. And okay, very good. So we do have some questions. So let's go over those. And so it's, what is the best cannulation for VV ECMO? And I think that was for Roger. Mm-hmm. So let's go ahead and just go through each of them. So Roger, you're on. And if you just move to the left another couple of inches, that'll be good.
Okay.
There you go. There you go. You're good. Don't move now. You can't move anymore.
10 intensivists would argue all day about the best cannulation, and I'm not on their caliber, so I would hate to venture a guess. But different cannulas present different problems. The dual lumen cannulas are nice, but you're stuffing a lot of blood through and expecting to drain a lot of blood back through very tiny ports. So you're going to get a lot in the way of shear stresses, high velocity drop as soon as it enters the atrium. The smaller the cannula is, it presents a lot of normal problems that a perfusionist would see during any cardiac case, same as putting in an aortic cannula that's too small. The single lumens work just fine if the position's correct. As far as the best or worst cannula, I think any of them are effective as long as the size and position is right.
Mm-hmm. Yeah, that I think that makes sense. I'm curious. Do you think dual cannulation with femoral vein up to the level of the high IVC and right IJ, which one do you think gives you less recirculation? And I think that's actually what that question was meant to say, but they abbreviated it. They're probably a Twitter user, so they use as few characters as possible. Which cannulation technique do you think results in the least amount of recirculation on VV?
Properly placed single lumens would give you better drainage. The ports in the dual lumens are smaller, but it affords you to put in a smaller hole in the neck. And there's 6 or 7 sizes for origins and avalons. Crescents don't yet have pediatric sizes. The problem is there's an infinite number of sizes and anatomical shapes to the patients. Mm-hmm. So an identical position on one patient may not be nearly as effective on a similarly sized patient the next day.
Mm-hmm. That makes sense. So last question, and if you could just, can you put me on the screen for a second? So Roger, just imagine this, and this is something that I learned from Dr. Bruckner, Brian Bruckner. So what he does is he takes and puts a long venous cannula up the femoral vein and in the right atrium. And then he puts a femoral venous cannula in the contralateral vein, and he puts it up and he leaves it low. And so he's taking advantage. His access is the low, his return is the high, versus this direction where you're coming from the femoral vein and going back into the IJ. He does it this way, taking advantage of the natural flow of the venous circulation back to the heart. And go ahead, back to them. Have you tried that technique, and what's your thoughts about it since you've worked with this so much?
I haven't seen that used, but it makes sense. You can see from the studies that the one study that came out last year, there's a real deficit on the IVC port. Even though it's facing right against the flow, the blood tends to want to wash right past that nice tip and keep right on going into the atrium. Having a vacuum type area, an extra port on the in the IVC would certainly increase your drainage down there.
Mm-hmm. Okay, very good. And then I think you had a compliment somewhere. This is absolutely going to help me take care of my patients. That was towards you, Roger. That was when you gave your talk. That was yours. And that was from Dr. A. Bonsall. So kudos to you there. And then what is the best cannula? We had talked about that. Do you see, okay, this I think is to you, Dominic, do you see more hemolysis with the screw pumps versus the centrifugal?
I would have to say anecdotally that answer is correct. We typically measure LDHs, and it seems to me that in the centrifugal pumps it's below 200, and with the axial flow pumps it can be in the mid 200s to 300s. There's probably articles out there that say why. My guess off the top of my head is that the flow pattern and the speed of the centrifugal pumps is lower than the axial flow pumps, so that could be due to part of it. Just anecdotally, we tend to see less hemolysis in our two centrifugal pumps than we did with our axial flow pumps. It's not bad in either one, but it's probably a little bit lower in the centrifugals.
Very good. And then who do you believe should be responsible for monitoring the ECMOs at the bedside, Dominic?
Oh, I'm not going to get into that one. I think it's program specific. It's very program specific. You know, we certainly did that for many years, and it worked. The way we do it now works. I think it just depends on a lot on your program, a lot on your resources. And the only thing I will say is I do feel that the directors or the management or the oversight of all ECMO programs should be perfusion and not nursing or respiratory therapy. That's the only thing I can say. I mean, you got to have someone that's their only job and their only training. So, and they've been doing it all day, every day for their entire career. But as far as who manages it on an hour-by-hour basis, very program specific.
Well, I'm going to get into the next couple of questions, but first I'm going to turn this over to Tammy, because Dominic, you mentioned something about microcirculation earlier, and I'm really curious to see what Dr. Mathura thinks about ECMO, continuous flow, pulsatile flow, these new VADs. You do? Yeah. So why don't I turn this over to you, Tammy, and why don't you go ahead and ask your questions, and you can ask them of anybody at this point. So we've covered Dominic. The only person we haven't asked is Dr. Mathura anything, but I think we can now open this up a little more because Roger and Dominic were very kind to have stayed as long as they have. We just appreciate you guys a lot.
Yeah, thank you so much. I did have a real quick question for Dominic. In your HeartMate 3s, I believe you said that was the VAD that you had most experience with right now, with about 120 on support patients. I wondered, are those destination VADs? Are they more waiting for a transplant? And then what if they are waiting for a transplant? What are your explant success rates with that?
I think I must have been confusing on that part. We have 120 patients total. Okay. I would say probably 50% are Heartwares, 40% or 30% are HeartMate 2s, and another 20% are HeartMate 3s.
Okay.
The majority of our patients now are actually destination patients. Okay. I think most medium to large programs, that's the case. It's flipped 180 since I first started doing this, where 95% were bridge, and now maybe 30% of our patients are bridge to transplant, maybe 5% are recovery, and the rest are all either DT or bridge to decision. There's patients that can move from being a destination patient over into the transplant arm if they are cancer-free for 5 years, or improve their compliance, things like that.
And a real quick follow-up to that. So since we've had so much of a growth with this being as a destination type therapy, why do you think that is? Is it a combination of a shortage, we have more patients that are sick and a shortage of transplants, or do you think it's because the devices have improved and the quality of life and durability has improved greatly, so that this is a real therapy instead of just kind of a Band-Aid waiting for something else?
I think the latter is the biggest part of it that I've noticed. The management of these patients and the patients that get funneled into your system now is so much better than it used to be. I mean, there was probably, a ton of patients that we missed just because their cardiologist wasn't aware that this therapy was out there or how much it had improved. So a lot of it is cardiology management. A lot of it is, our doctors go out and do outreach programs and to get these doctors to say, hey, if you've got a heart failure patient that's not doing well on medical management, whether they're a transplant candidate or not, we have a viable option to improve their quality of life for, however many years. I think a lot of the patients now are, 3, 5, 8, 10 years out. Maybe not a lot, but it's heading that way to where it's a viable option. Their quality of life is better. They're out of the hospital more than they're in. And a lot of it has just been due to better management experience and, people seeing good results. You run into a VAD patient bagging your groceries or, in your college classroom, things like that. It becomes more of an option for people that may or may not even be waiting for a heart, that just want to have another 5 or 6 good years or 10 good years.
Right.
Wow. Do we, a question, did you work with Dr. DeVries, Dominic, by the way?
I did early in my career. I didn't do any of his VADs with him or his total artificial hearts, but he worked in Louisville for probably my first 3 or 4 years as just doing general cardiothoracic surgery. Really nice guy, a lot of fun to work with, always had a good story to tell.
I tried to find him for the past couple of years, and he's gone incognito. I can't. I even called Dr. Jarvik, and he couldn't find him either. So, Dr. Mathura, okay, so let's get to you here. Continuous versus pulsatile flow. We're perfusionists. We put people on bypass all of the time. We have a big controversy at times about whether we should be flowing continuous on cardiopulmonary bypass or whether we should be flowing with pulsatility. The problem is the pulsatility we can create has a pulse. It's more like a sine wave. It really doesn't have much of a pulse, maybe a 20 millimeter of mercury gradient. How much work has been done from that you're aware of where the microcirculation has been observed during cardiopulmonary bypass during different sets of circumstances?
Yeah. So there a few studies have been done trying to figure out this exact question. What is interesting is that the laminar flow, the continuous flow, what you see is that as the surgery progresses, more and more capillaries disappear.
I'm not surprised.
Right? So a short surgery of an hour will have less of an impact than a longer one probably due to this disappearance of capillaries. There are, I think, 2 or 3 studies done on pulsatile flow in cardiopulmonary bypass, and they do show a preservance of these capillaries. But these are 10, 12 patient studies, so I wouldn't call it definite, but there is a trend, let's just say, that pulsatility might preserve the microcirculation better than continuous.
Very interesting. Okay, so how does that then correlate to how we look at the total artificial hearts that are being developed now? They're all being developed as continuous. Is there an adaptive process that takes place? So for us, just sort of to lay some groundwork, the longer your pump time when you do a heart, the more, I mean, it's a predictor. It is itself a predictor of mortality. So either all kinds of problems occur once you've reached 4 hours, 6 hours, and then it becomes almost futile. And not always, but more frequently than not, I would say. So these patients that go on the total artificial heart that are continuous in nature or laminar flow in nature, how does that then correlate?
Good question. We don't know. I guess there must be I would guess that there's an adaptive mechanism going on. We do know that, for instance, we've done one or two studies on an impella. And it shows actually that if you turn it on, the microcirculation comes back beautifully. And when you turn it off, it just disappears again. So there is something there. But the mechanisms, the physiology behind it is just unclear.
So I had one last question in deference to time. Actually, I have 100 more questions, but I'm going to limit it to one more. You talked about patients who come in that may respond to a fluid challenge. And in some of those cases where fluid was administered, you saw an increase in the microcirculation, the small vessel density, and therefore better microcirculatory perfusion. Is there any information that you have or sense that you have or opinion that you have regarding those fluid challenges being crystalloid or blood or albumin even?
Well, not crystalloid or blood. We do have crystalloid versus colloid, which is also a big debate in itself.
Yes.
It turns out that on the microcirculation level, it does make a difference what type of colloid you use. So the crystalloid has, you see an effect or you don't. But even in the colloids, not all colloids are created equal, which is kind of also becoming clear by now. So I just saw a few weeks ago a paper published by a group associated with Fresenius Kabi, one of the biggest fluid makers in the world, I would say. And they have just released a new colloid, and there you see a beautiful, restoration of the microcirculation with a very tiny or relatively tiny fluid challenge. I can't remember the exact numbers. Whereas a more traditional starchy solution, you didn't see it. Well, of course, it is a paper from a hospital associated with them, so we have to be careful. But there is something there for sure. And blood, we do see that, for instance, the debate, old blood versus new blood.
Yes.
That old blood does not do, it does improve the microcirculation, but not as much as relatively young blood does. So there is something there.
How would you use this device? Okay, so we get this device.
Yeah.
Right. Yeah, good call. You ask.
Well, I was wondering, currently, what's your major application that you're seeing, your device being used, and how do you think this could be used specifically to us in our field with ECMO or even on cardiopulmonary bypass, studying pulsatility cases versus non-pulsatility cases.
Or even assessing the quality of our perfusion.
Yeah, or that
Are
too.
we perfusing adequately? Is what we're doing good?
Yeah. Well, actually, so the numbering system is really, you can just store the images and have them analyzed by the algorithm. But what we notice, actually, most physicians, they just it's almost like drawing a blood sample. You just draw it, you have it analyzed, and the nurse comes back to you and says, okay, well, it was this. And you say, okay. So what they do is they just have the nurse or they themselves do a measurement. They look at it. Oh, this looks better than half an hour ago. We're good. And they're not even waiting for the analysis, or they're not even doing the analysis, or maybe they have a nurse do the analysis later. But they're just looking at the image and saying, okay, well, this looks better. I'm good. Oh, wait, I changed something and I see less capillaries. Oh, wait, I need to go back to where it was. Because the microcirculation responds really, really quickly. It's seconds. So, you can even hold the microscan in the mouth, do something, and you see the change.
Wow.
So you're using it
seconds
more like a
later.
point-of-care
So
device.
it's really like that. It's really interactive. I did something. Let me check. Oh, it's better. I'm on the right track. It's like really guiding what you're doing.
Very good. Roger, Dominic, do you guys have any questions for each other? Dr. Mathura, do you have any questions for us? You guys can maybe, interact with each other, and we can close this out with a few more questions, and then you can get some sleep, and Dominic and Roger can go out, go get dinner, party, go dancing. They both look like those guys look like they really tear it up. So we'll start with you, Roger. Some final thoughts or questions?
Well, one I had is how well would the capillary imaging work with bubbles?
Well, we had a few studies done with bubbles in, I think it was a rabbit or a rat model. You could see the bubbles, but they moved past very, very quickly. So you had to really rewind the video and see them pass. But you could see them, yeah.
Wow.
Wow,
that is a good question.
That's a great question.
Yeah.
Dominic?
I wanted to just make one quick comment. When that question was asked about who should sit ECMO, and our group is fortunate in that we have a CVIC staff, CVICU staff that's very trusting of us and also is very competent and very experienced. So I think a lot of that depends on where your patients are going to be. Our chief cardiac surgeon decided years ago that he wanted basically 2 central floors for his VAD patients and his ECMO patients. The VAD patients start out in the CVICU and then they go just up the hallway to the step-down unit. So it's all very centrally located. The staffs know each other. And as far as ECMO, we have one unit where all our patients go. So the same nurses are taking care of the same ECMO patients. They're not in 3 different units, CCU, surgical, cardiovascular. They're all in one unit. When we go get patients for other hospitals, we bring them back to that same unit. We try and implant them in the ICU itself. I know some places will actually take them down to surgery and implant it in surgery, which is fine also, but we've gotten pretty used to just cannulating and implanting in our unit. And someone mentioned Joe, I think it was you that mentioned the 2 venous cannulas, one up high and one down low. Mm-hmm. We found that works pretty well. We use the Avalon. One of our thoracic guys likes the Avalon a lot. But that is, I found, trickier as far as positioning, and we end up moving the Avalon a lot more than we ever have to move our 2 venous cannulas, one high and one low.
Mm-hmm. I like that. I think I'm going to advocate for that more. The problem is you're going into the groin, and nobody wants to be in the groin. You can't sit the patient up. You certainly aren't going to get the patient in a chair, and you have increased infection risk, especially if they have if they're a little overweight, which is frequent with our patients. Okay, well, with that said, go ahead and put the fellows back up. Dr. Mathura, any final thoughts?
Well, I was actually very interested, wondering if there's any interest in trying a microscan on the VAD patient, the patient on the VAD device, because that would be, I would assume that it requires some tinkering to get that patient optimal.
Dominic, that's to you.
Settings.
Yeah, I think it'd be great, especially we have some patients that have those recurrent GI bleeds, and I think what they've kind of decided is that a lot of people have AVMs, but not a lot of them will progress to GI bleeds. There's certain patients that just have a propensity from that. So it'd be interesting to see if our recurrent GI bleed patients are different than our ones that don't have the GI bleeds, and what's actually going on with the microcirculation in their gut more than anything, probably. Yeah, I'm sure there'd be people interested in doing that.
Very good.
Have a chat.
Excellent. Well, I know a lot of folks right now that are begging me to get this. Dr. Kumar and Dr. What was his name again? I forgot his name. Zubietta. Both of them are intensivists up here in Houston, and they're I know you shipped me one of these devices. I'm going to need to get some instructions from you, but they're begging me to bring it in, and I'm going to take full advantage of having this toy that they want to play with. So look, I want to ask all 3 of you, will you all agree in maybe a different day of the week, maybe not so late, maybe a weekend or something, a Saturday, something that's not quite so difficult. And maybe even after we've had a chance to, we've got a new toy for the studio, which will enable us to do more windows, actually have 4 of them up, but we just got it, and the guys need to learn how to use it and tear all this apart and then put it back together again. So, but I would hope that, and I'd really appreciate if you guys would all agree to come back on and do more lectures, because I've gotten some YouTube comments, and Nestor said that that your presentation, Dr. Mathura, was mind-blowing presentation and well worth the price of admission, and more comments complimenting both Roger and Dominic for very, very informative and comprehensive discussions. So presentations, discussions. So everybody's very, very happy with all of you, as am I. I'm actually humbled to be around, to be able to be in the same cyberspace with you all, much less space, much less room. But you all have to agree that you'll do more of these for us, and we can continue to expand on this, because I think this is very interesting for a lot of people, and it's going to benefit a lot of people in the long run.
Sure, no problem.
Yeah,
So,
of course.
Okay, so Dr. Mathura, to sleep for you.
Thank you.
And Dominic and Roger, once again, thank you guys. I appreciate you all so much.
Well,
we're all going to Amsterdam and meet with Dr. Mathura in his labs and see what's going on. You coming too?
I'm absolutely going.
Okay, Tammy's coming too. All right.
Super welcome.
Good night, you guys. I'm going to say good night to our audience and then close this up. But thank you all so much.
Thank you. Have a good night.
You too.
Good night. Bye-bye.
We finished right on time, almost. Okay, so we're back. What did you think of all that?
It's pretty fascinating.
Wasn't it? All of it. I mean, Roger was brilliant.
Yes.
Dominic is, I mean, with that whole idea of research, being able to really assess that and know, you know, we're on ECMO and this isn't working worth a darn. Well, it's not working because of this. We know the reason.
Right.
I think Dominic, with his information and knowledge on VADs, was incredible. I mean, the guy knows VADs better than I think anybody down here in the med center. I mean, he knew his stuff. There was no question about it. And Dr. Mathura, I don't know what to say about that. That was just crazy. Were those images not impressive?
They're crazy.
They were impressive.
They were.
Yeah, and he's such a nice person.
Could have asked 30
It's
more
1 o'clock,
questions.
me too. It's 1 o'clock in the morning where he's at.
They changed the time.
Oh.
On Sunday, so it's one hour less.
Oh, so now it's only midnight.
Yes.
Poor guy. Still, you think about it, you know, think about it. Well, it's 6:30, it's 12:30, midnight 30. He probably has to be up early. Okay, is there anything that I have forgotten? Okay, everybody, for the last time, if you're on YouTube, if you're on YouTube, you have to click subscribe and thumbs up. We don't have that many thumbs up.
Enable notifications.
And notifications, but do the thumbs up. If you're on the Facebook and watching this, click the like button, is that right? Or the thumbs up there too. Thumbs up. And if you're on the tweeters,
Love it.
then love it, yes. I want hearts, I want all hearts.
You didn't talk about the poll. Got to talk about
Oh yeah, we need to, the poll didn't go too well. We had technical difficulties on the poll.
Okay.
Poll's out. And then what do they do with LinkedIn?
I don't know.
You like us on LinkedIn too. Okay, so like us on everything. Okay, our next program, and those guys are coming back. I'm going to tell you right now. I could spend the whole session on any one of them individually, and I think that's what we need to do.
We do.
We need to do longer sessions with one as opposed to having so many, because it's hard to compress all of that in, but they all sort of had something to do with each other.
They did.
Which I thought was interesting. Okay, so let me see. Our next program, can you throw that up and see what our next program is? It is going to be on November
the 12th?
23rd. Nope, November 23rd.
23rd, yeah.
Tammy's not going to be here.
No.
You're going to be on vacation.
I will.
But I'll find another victim. Don't worry. And it's going to be on extracorporeal life support as a bridge for pulmonary hypertension. That's a big problem. It happens. That's really a common diagnosis. Dr. Zubieta is going to be talking about the management of common electrolyte disturbances in the critical care patient and especially the ECMO patient. which I think is going to be very good. And then I'm going to do a demonstration.
Oh,
and this
sorry,
is going to
I'm gonna
be,
miss this.
I know, well, you can watch it. This is going to be the first time I've ever tried the demonstration, but we're going to repeat it. So we're going to do it again in December.
Okay.
So December's program is going to be big. It's going to be like a 8 CEU, at least 6 to 8 CEUs. And I'm going to redo it, but I'm going to do the first time, I'm going to try building a system that you can have a patient on VA ECMO and you can angiovac simultaneously from a single circuit, a pulmonary embolus from if it's a saddle block embolus, and be on VA ECMO at the same time in a single circuit. So I'm going to build it and I'm going to try it. The first time I'm going to try it, I'm not going to test it until I come in here. We're going to get the green screen. I'm going to try it. It may work and be beautiful. It could be an epic disaster. I don't know, but that's what's fun about live TV, right? That's what makes this all fun, is you got to just try it and see what happens. Is there anything else I'm forgetting?
No.
Anything I'm forgetting? David? No. Nothing I'm forgetting? Okay, so the next time we see you all, we're going to have a new streaming system that is going to be able to do even more than what we have now stressed the system that we have to be able to do. And I think that that's going to alleviate a lot of the stress that the technical folks like David, the producer, and Magic, the technical guy, have. Because I think that I have annoyed both of them tremendously today. And but they love me anyway, I think. I'm hopeful. So thanks a lot back there.
It did not sound encouraging.
No, it did. Okay, so I'm going to see you all. Remember, you got to take a short quiz, get your certificate if you signed up for CEUs, and I will see you all on the 23rd, Saturday the 23rd, for a great program with Dr. Samir, Dr. Zubietta, me, a great panel. I know Mike Brown is going to be here. He's already said he would be here. I think Rodell said he would be here. So I think we're going to have a good panel, though I'm going to miss you tremendously.
Maybe I'll call in.
I would love for you to call in and laugh at my you know what? There's a thin line between genius and crazy. I'm kind of hoping that, hey, look, I coined that phrase.
That was a good phrase.
Okay, that was a good, I thought of that right here.
Mm-hmm.
Okay,
On the fly.
I should get credit for that.
Mm-hmm.
Okay.
It's been chronicled.
It has been. Good night. See you on the 23rd.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.